Hello everyone, welcome to Sensemaker Live at Tortoise, brought to you in partnership with Santander. Thank you very much, Santander. It's been a while actually, because we used to do this every Friday lunchtime, but before Christmas, for 3 consecutive Fridays, we had our inquiry into COVID and the government's response to it. And then we went all frivolous and had, as I recall, a creative Sensemaker Live just before Christmas. And boy, have we come back to reality with a bump in this first working week of January. A lot of us have been a bit preoccupied with the life and death of democracy in the US. But we've decided to stick with this subject, the vaccine rollout, on which so much depends in this country and around the world. I mean, this is the life and death of tens, hundreds of thousands of people at issue. It's hard to overstate the importance of it. And the big question that we'd like to address is a deeply practical one: how to make a success of this vaccine rollout. We're inevitably focused on the UK because that's where most of us, but not all of us, are sitting. But and we are, it feels like, in a particularly frantic race against the virus because of the Kentish variant, which started here, as far as we know. But of course, everything that works here, that applies here, applies equally all over the world. We've got 4 incredibly informed guests who I'll be coming to first. Thank you all for joining us, and I'll introduce you in turn. But first and briefly, for those who haven't been to a Think-In before or have forgotten since yesterday or the day before, the point is that everybody gets to pitch in. You can do so. We want to hear your point of view, especially if you have personal experience of the vaccine rollout so far, whether as a recipient or perhaps even as a vaccinator. I think, some of us will have an idea of the big picture, but very often it's the details that are really revealing about what's working and what's not. There are 2 ways to get involved. You can type, if you'd prefer that to talking, in the chat. And Phoebe is monitoring the chat. Hi, Phoebe. Or you can raise your electronic hand. Now, I know that there's a new way of doing it in this version of Zoom, and I'm not going to make a fool of myself by telling you what it is. Phoebe, is that something? Can you help us? How do we raise our hand nowadays?
It is now in the reactions part rather than in the share in the participants.
Click on reactions, and there you've got your raise hand option. Thank you so much. Okay. Well, as it turns out, our 4 guests, this is a forum for civilized disagreement. And so we're going to keep it civilized, whatever happens. But as it turns out, we have 2 who represent one particular point of view on an urgent question and 2 who represent another. So let's start with this question of the gap between the 2 doses of the vaccine. At present, the UK government has adopted a policy of first dose first, so that even though the recommended gap between, for example, the first and second dose of the Pfizer vaccine is 3 weeks, 21 days, at the moment, people like my parents who got their first dose yesterday are being given a date for their second dose 12 weeks hence in April. Now, Professor Herb Sewell from the University of Nottingham, who's with us, is the co-author of a recent paper, hi Herb, in the BMJ, explaining why you don't think that's a good idea. Would you like to start by setting out why?
Initially, well, the top level argument is that we have, let us say, we have 2 vaccines authorized, which have gone through stringent clinical trials, which have basically defined clearly the parameters for scheduling the doses. Okay, so that's gold standard randomized controlled trials. The government has then decided, basically on the public health argument, stating initially that there was a shortage of vaccine and therefore an alternative strategy, first dose, and then extend out to as much as 12 weeks, and that will potentially double the number of people that can be vaccinated. That is appealing from a public health scenario, and also, of course, emotionally very appealing if we're thinking about, as they tend to always want to tell us, you can do both of your grandparents rather than one. However, John, myself, and others, we feel there are some inherent risks in pursuing a strategy that has no scientific underpinning. And indeed, Pfizer-BioNTech and Moderna have said they have no evidence of safety and efficacy beyond the time periods that they've specified. The other reasons, which we've articulated in our commentary, in our blog, is that we see risk at least three levels: risk to the individual, potential risk to the population, and if I could just explore those in turn. So the risk to the individual, if you extend, let us say, beyond 50 days, 60 days, we have no data on that. And the possibility is that you could have a waning of the immune response to a level where it is not protective. Now, the counter argument have come from various circles that, oh, but we've got evidence from lots of other vaccines that if you extend, the second dose, you get as good a response, or sometimes even an enhanced one. And that is correct if you look historically at things like tetanus vaccines or any other microbial vaccine. But what I will argue is that the stimulation that you get, particularly from the mRNA vaccine, is different, vastly different from the standard regimens that we use. For the first time ever in human beings, you're using as the immunogen a piece of genetic material which is injected, taken in, translated, and then expresses the protein, be it on the surface of the muscle cells or wherever else. But the reality is that we know from lots of work that even with the modifications that have been put in, mRNA as an immunogen doesn't last long. It's gone within days. So the protein that's been translated and expressed, that's it, it's a one shot. And then that protein disappears in relation to its half-life. Contrast that with the standard injections you would get with adjuvants or whatever else. Those antigens stay around for ages. They're picked up by antigen-presenting cells, they're on dendritic cells, etc., and they stimulate for long periods. The risk is that with the mRNA, you will not have that longevity, you will not have that long stimulation, and you will have a waning of the immune response. And others can come in a moment, but I would say there is also now some preclinical evidence which suggests that may indeed be the case. There was a beautiful paper published in Immunology at the end of December, where they use a mouse model and they use the mRNA vaccine equivalent to what's in the Pfizer-BioNTech vaccine. And what they showed in that mouse model, following the first dose, after about 28 days, you have a marked fall off in some markers of specific immune responses, which also translated to a marked fall off in the neutralizing antiviral antibodies. So I think we're having some preclinical insight that's telling us that this isn't just a theoretical concern, it may actually be a real concern.
Okay. Yeah.
And John, I think, will add his perspective.
Right. Thank you very much. I'm glad John's with us. Before we come to John, let's go to Dr. Eva Thorne from the Tony Blair Institute for Global Change, because you've put out a report that recommends first dose first, and this is now government policy. Would you like to set out the broad reasons underpinning this recommendation and answer, if you want to, the specific point that while a longer interval might be appropriate for more conventional or familiar vaccines, these mRNA ones are new and we simply don't know.
So for that question, I'm going to defer to my colleague, Dan, who has taken the lead on this issue. I'm more on the international side of it, but I'll jump in as necessary. But Dan has done the bulk of the work on that one.
Okay, let's go to Daniel, also from the Tony Blair Institute.
Hi, everyone. Yeah, thanks for having me. Two quick warnings. My blind rescue dog, when he hears other people's voices, thinks there's someone for him to come and say hello to. So if he disturbs me, I'm sorry. And other quick one, obviously Herb and others are genuinely expert in this. I'm just sharing my perspective from having done some research with Tony. So absolutely, I defer to those that know more. So just putting across our point of view from the conversations that Tony had before Christmas with scientists and the companies involved. Obviously, there's a very, there's the scientific perspective that Herb has shared. In the end, Tony thinks that it becomes a political judgment what to do when you're facing this scale of the challenge. I think without the vaccine, you could make a very good case that we're in a worse position now than last March. We're at risk of being overwhelmed. There's the Kent strain, the South Africa strain. We need to do something very urgently. So he said, why not look at the first dose for many strategy, following up with the second dose when possible. Obviously, as Herb said, Pfizer have some concerns about that. If that's the case, then absolutely we should seek to do the second Pfizer dose as soon as possible. For those that have had them, I think Sudi in the chat, her dad's had the second dose, which is great. We understand from AstraZeneca, they are much less concerned about doing a one dose for now strategy and following it up with a booster in time. So on that basis, we think just to get as many people with some protection right now in the midst of, I think personally, the worst part of the crisis, has some political judgment to say that we should try that. The last thing I'd very quickly say is a missing part of this, I think, is data. We need to be doing a hell of a lot more to capture all possible data on testing, vaccinations. And I think this would allow us to respond very, very quickly. If any of the issues emerge that Herb has set out so well, we can then go back to people very, very quickly through this portal to say, right, we're bringing you all back in for booster shots quicker than we expected. So absolutely, I accept the health warning that Herb says. We recognize, yeah, Pfizer has a concern. Let's do the Pfizer second dose. AstraZeneca, less worried. We think it can give us more coverage. I think AstraZeneca is going to become the workhorse vaccine over the next few months. Let's get it to as many people as possible to get some immunity while we're in this very, very difficult phase. That's our point of view anyway.
Okay, fair enough. Daniel, while we're talking, I noticed there's Mehdi and Anthony Cope in the chat are saying forcefully, this is not a political issue, it's a science issue. Politicians need to stay out of this. Are you saying, sort of on behalf of the Institute, fair enough, in the circumstances, we defer to the expert advice, and while we continue to advocate first dose first for the AstraZeneca one, we no longer do for Pfizer?
When Tony set out his argument before Christmas, it was a suggestion on how we could try to get more coverage for people, given that the vaccine is the way out of the problem. It was something to explore. I think it is worth looking at it. As I said, AstraZeneca, they seem less concerned. Let's try that. Pfizer, if there is the issue and Pfizer are concerned, absolutely, let's do the second dose. I very respectfully disagree with the people in the chat. I think absolutely there's the scientific base to it, but in the end, whether we like it or not, this is a political decision how to handle it. And the political decision at the moment is we try to get as much coverage as we possibly can with some protection rather than have less people with more protection. So we go with the science, absolutely. If there's a case for trying that with AstraZeneca, let's do it and see. The more people we can give some protection to, the better. If there's an issue, let's not do that. But for the time being, I think there is a case for trying it, just because, as I've said, I think we're in such a very, very acutely difficult part of the problem. And the Joint Committee on Vaccines endorsed trying it, which I think is why the government moved position. So I think there's a case for let's see if we can protect more people.
Thank you, Daniel. Eva, we'll definitely come back to you on the global picture. I can see Herb raising his hand. Herb, should we come to you? I was going to come to your colleague, John Robertson, but if you want to dive in, please do.
Positive rejoinder. I don't disagree about the AstraZeneca Oxford vaccine, because for that, there is some data that you can extend it out for some time and still get a good protective response. That actually has, from the clinical trials, some very limited data, but it also has some ample precedent where that vaccine construct has been used before. So I am more relaxed with the concept of extending the AstraZeneca Oxford, but absolutely opposed to doing that for the mRNA vaccines.
Okay, thank you. By the way, can anyone hear the Maple Leaf Rag in the background? Because if so, I'll go and tell my son to stop playing. No? Okay, good. Let me come, if I can, to Professor John Robertson, also from the University of Nottingham, also a signatory to the BMJ piece. Hello.
Hi, Giles.
Basically, I'd like to put to you Daniel's point, which is let's park the whole question of whether politicians or not should be involved in this, and let's accept the well-intentioned advice of an organization led by a former politician who arguably proved himself a better crisis manager than the one in charge now. Is there not a case, a basic first principles case for saying, because of the Kentish variant, we are in crisis mode, and whereas no one would ordinarily advocate using a new vaccine in anything but the circumstances in which it had been trialed, we are in uncharted territory, and there's a straightforward common sense case for doing whatever we can to make that practically vertical line start to bend towards the horizontal.
Thank you for the invitation to speak. I would just pick up on a point you made and correct that I'm not sure that the person you referred to was good in every emergency. I mean, I would point to Iraq maybe as an example of weapons of mass destruction, where that advice was not necessarily is good in an emergency situation. But
fair enough.
Let me pick up on the point, which is that you have to have expertise, and I think when politicians do make statements, they have to think of consequences too. And I think a lot of people have reacted badly to this because of wrong messages to patients as well and to the public. But I would pick up on the science and the point somebody made. You have to follow the science, because if you don't, you're going to get into a lot of problems. And the science, being led by the science, means to take it on board. I agree with Herb. I don't want to go over the issue of AstraZeneca vaccine. I think there's much more opportunity for that. But I do want to pick up on the Pfizer. Herb has outlined the science.
John, can I just say that I can hear you much more clearly when you're looking slightly to tilting slightly to your right. Yes.
Okay, is that better?
Yeah.
Herb has laid out the science for that. So I just want to pick up on some of the implications of not following the science. I think there are enormous consequences. We know what this vaccine gives us at the scheduling we've been given, right? And remember, this is not the normal approval. This is emergency authorization, which tells you that there is limited data. And to move away from that limited data creates uncertainty. And as Herb has said, there already is no data to support that for the Pfizer vaccine. In fact, the data from the animal data is it could be dangerous, because the immunity drops off after 21, 28 days. So in that period between the extended first and the extended second, you've got less immunity. And secondly, when you come in with the stimulation, you may have less long-term immunity. So you're potentially creating a problem. And that leads me to my next big issue, which is that I think that the CMO and the CSO in some of the briefings have been correct in what they said, but not completely transparent in the issue, and that's to do with the issue of risk. For example, we're now seeing variants, and when they say there's a very small risk of a variant, I think probably a month ago we might have said that's okay, but in the last month we've seen 2 variants appear, one of which, particularly South Africa, could be really important. And the issue about risk, you can't just look at risk. I deal with risk every day as a cancer surgeon. You have to look at consequences. And what I say to people is, you look at the cold, nobody takes precautions against the cold because the consequences are small. But you look at the space shuttle, they took enormous precautions. And you see what happens when something goes wrong, the O-ring goes and the Challenger goes down. Enormous consequences for those 8 people. The issue here is that we will get variants by giving people ineffective vaccination. And what will happen is you will bring out those variants which may not be responding to the vaccine because you haven't got enough antibodies. And the consequences of that will be that you will get a variant appears that becomes dominant. And so the vaccines don't work, and it will be a catastrophic outcome, and not just for 8 people in the Challenger, but for the whole of the UK and for the world. So you can't simply say the risk is small without looking at the consequences. And the risk is probably higher now than it was a month ago, seeing these variants appearing, and the consequences are catastrophic potentially. So, and that's not been discussed at all with the CMO and the CSO. We're always being told how small the risk is, and we have to look at that. The second point of data I would make is that, in fact, the government came out 2 days ago, the Minister for Deployment, Mr. I think Zahawi, said actually that doctors could still use discretion about giving
John,
he said doctors could still use discretion about giving the vaccine at 21 days, the Pfizer vaccine. And I think the government have to be more clear about that and to say, look, there is good scientific data and that we really we're talking specifically about these vaccines, the Moderna and the Pfizer vaccine. They should come out and say, look, doctors can use their discretion. And in fact, the science would point us to using it earlier, not just for the individual, but for the population as well.
Thank you. John, what is your understanding, and anyone else by all means pitch in, on obviously the Joint Committee on Vaccines and Immunisation has signed off on this. What about the MHRA? Have they had a role in that?
My understanding is the MHRA is still approved the normal schedule, right? They've approved the schedule that was given by Pfizer, which Pfizer have only endorsed. In addition to that, the FDA have only approved it. In fact, they made a very strong statement that they would not approve anything other than 21 days for Pfizer and 28 days for Moderna. The EMA have also said that they'll only approve the approved doses. The CDC have only approved that, and the WHO have only approved it too. Now, again, coming back to politicians, yesterday, for example, I think at the Select Committee, Matt Hancock was asked about this, and he said, it said, I think it was WHO said, in exceptional circumstances. Well, the pandemic's not exceptional. They are exceptional circumstances, but what they meant was, if, for example, you get a vaccine today, Giles, and you had an infection at 28 days and you couldn't have the vaccine, that it would still be worthwhile giving you it at 35 or up to 43 days. But that's for you as an individual, that exceptional circumstance. It's not behaving that way for the whole of the population. And so that was the misleading statement, I think, by Matt Hancock yesterday. And we have to get clarity on these issues, I think, in terms of this, what veering away from the study data shows what the implications of that are and for whom it should be. That variation should be an individual exceptional circumstance, and you should be looking at the potential consequences as well as the potential risk.
All right, thank you very much. Let me come to Dr. Eva Thorne now. As you also from the Tony Blair Institute, as you explained, you've been looking at this from a global perspective, and the report that you've put out covers a great deal more than first dose first. And the overall aim is to accelerate the vaccine rollout. Would you like to set out what you think are the practical measures that could be taken to do that which aren't being taken at the moment? I mean, I note, for instance, that you're proposing an aim of 3 million vaccines per week. As I understand it, the current aim is 2. And I wanted to ask you about that specifically in a second. But do you want to give us your big picture of what could be done that isn't?
Well, on the global level.
Yeah.
So I think that there are issues of supply, and then when you get into countries themselves, there are issues around the infrastructure necessary to support the rollout. So the sad headline is, and we know this already, but it bears repeating, there's simply not enough doses to go around, even if we're talking about immunizing the 20% threshold that COVAX, which is the international private-public partnership facility responsible for procuring vaccines for the developing world, their goal is to immunize 20% of developing countries' population, which would basically mirror what we're talking about in the UK. So people who are in care facilities, those who are vulnerable, the elderly, healthcare workers. The good news on that front is that as of the end of December, beginning of January, COVAX was able to raise about $2 billion plus. I think it hit 2.4 billion to have, I think it's 1.3 billion doses available to roll out in 2021. So if that is a 2-shot regimen, it depends on which ones they have, basically 600 million people. And if you think about the global population of over 7 billion, and most of the developing world is maybe like 6 billion, 5 billion, 6 billion, it's just not enough. So there's a problem with supply that's related to funding, and it's also related to the manufacturing capacity that exists. You can only produce so many doses. And I think one of the things that requires some exploration is really how many doses available are there? We add up all of these reports that we're getting about COVAX facility has purchased X amount, bilateral deals total this amount. How much of that is double counting? How much of that is an accurate understanding of what the total universe is of doses available? So that's one big issue. The second big issue is depending on the country's healthcare delivery system, government coordinating system, the challenges with rolling out the vaccines. So, obviously we've seen the problems with the mRNA vaccines in developed countries. For poorer countries that don't have the same kind of infrastructure in terms of cold storage, the AstraZeneca vaccine and the Johnson & Johnson vaccine, which should be going for EUA authorization sometime this quarter, are probably better bets in terms of ease of storage, ease of administration, especially for the J&J vaccine, which as of now is 1 dose, and just what the countries can handle. So there's also an issue around ensuring that the coordination mechanisms are in place to be able to reach the range of people that need to be vaccinated. The benefit that developing countries have is that they're used to these massive immunization programs for young people. And so a question on the table would be, to what extent can they leverage that experience to be able to scale up to vaccinate adults? I think a third challenge when we're talking about global vaccination efforts would be around the fact that at least 1 billion people in the developing world lack any formal identity. And so we're talking primarily about vaccinating adults. So things like digital identities, things like electronic immunization records, data storage and management systems that can put all of this information and data into one place to ease administration. It's a massive undertaking. So those are just some of the huge issues that I think are on the table when we're talking about dealing with developing countries and their need to have more of their populations vaccinated in light of these mutations that have been discussed.
Eva, what is your I can see you're using a good old-fashioned way of letting me know that you want to get back in, Herb, and we will come back to you. But Eva, what is your understanding of global manufacturing capacity? Because, as you say, a lot of orders have been placed, a lot of promises have been made, but by both politicians and manufacturers, and yet, certainly in the UK and the US, the difference between initial batch numbers promised and initial batch numbers delivered is very large. Are you saying that we simply don't know what global manufacturing capacity is?
I don't think it's 100% clear. I mean, I've seen a number of estimates. I've seen global capacity of 2 billion doses for 2021. And when you actually dig deep and look at the bilateral deals and look at the range of commitments, it's not completely clear to me that there isn't some double counting that's happening. And even if there's not double counting happening, we know for a fact that there simply is not enough vaccine to cover the amount of people that need to be vaccinated. And in light of these mutations, it seems to me, and I defer to the scientists on this, that more than 20% of the populations in these countries is going to have to be vaccinated. I know that there are different numbers and percentages in terms of what population immunity threshold is required, but there's a huge gap between what's available for developing countries and what exists, whether or not there is double counting.
Okay, thank you. Herb, make whatever point you wanted to make, but also if you know anything about global manufacturing capacity, do say.
No, I guess I need to just ask Eva. I know we're all very Western world centric, but you know, in this discussion, I don't hear enough about the potential of what can be delivered from. We have a couple of Chinese vaccines. We have what appears to be a very good Russian vaccine. Where is that in the equation about supply and demand? You know, we mustn't just, inverted commas, be arrogant enough to think that the Chinese can't produce high quality vaccines. We've seen data, in fact, this very yesterday, to say the vaccine that they have been using in Brazil has apparently shown something near 80% efficacy. The Russians have certainly in that ballpark as well. So, there's potentially significantly added supply out there. Has that been taken into your equations?
Go for it, Eva. You're muted at the moment.
Yeah, sorry, I couldn't get off. Herb, I don't disagree with you 100%. I would take one of the Chinese vaccines. I don't know if I would take the Russian vaccine,
Okay.
but I would probably take the Sinopharm and a few others. So they're not excluded. I didn't highlight them, and I agree with you 1,000% as someone who's worked on the ground in Latin America and in sub-Saharan Africa. So if you're 100% right, but the Chinese population is over 1 billion. We know that China and Russia are engaging in vaccine diplomacy. I'm not criticizing that one way or the other. But if you take into consideration the number of Chinese people who need to be vaccinated, even though they've done a great job of bringing the pandemic under control, would you say that there are enough doses to vaccinate all the Chinese who need to be vaccinated, in addition to the deals that they're making all over Latin America, all over Southeast Asia? They're doing priority access to some of their countries. They're extending low interest loans for countries to be able to buy the vaccines. At least the latest things that I've read out of the Council on Foreign Relations and elsewhere, there is a question on the table as to whether or not, even if you take into consideration the Chinese massive manufacturing capacity, there is a question as to whether or not there is enough, even when you bring the Chinese source on stream. So I'm not sure that there's enough to do what needs to be done in both China and in the countries that have this outstanding demand that are understandably and appropriately making these other deals. I don't know if what the numbers are on the Russian vaccine side. And I think some of this stuff is a little bit opaque because neither government has been 100% forthcoming with respect to how many doses are out there. I've seen piecemeal issues around Brazil, some of the Middle Eastern countries, but it's been hard, at least by the digging that I've done so far, to get a total count of how many doses we're talking about coming out of China, a little bit less transparency with respect to the number of doses coming out of Russia. So if you have data on that would be great. But I guess my final point is that it's not clear to me that even with China and Russia, there's enough for 6 or 7 billion.
Point taken. Thank you.
just before, I want to bring in some people from the chat, and I see you're raising your finger, John, but Herb, you say that, and you are the immunologist in the room, I'm afraid, unless there's anybody else who wants to raise their hand, that from what you can see, the Russian vaccine is, quote, very good. First time I've heard it. All that we read as journalists is that they never finished, phase 3 clinical trials, and that we can't trust it. So I'm fascinated by that take on it. What's it based on?
Yeah, well, it's based on, obviously, their published phase 1 and 2 trial, which was put out at the same time as the AstraZeneca data, Oxford AstraZeneca data. And I don't think anyone quarreled with that. So the expectation would be that the phase 3 would be, they haven't published it as yet, but the expectation would be that the phase 3 should have progressed much like we saw with the AstraZeneca. So, their phase 1, 2 data, it was smaller than Oxford AstraZeneca, but it was as robust.
And for you as an immunologist, is it a straightforward matter to look at the data from a phase 1 and 2 trial and assess whether it's genuine?
Well, I mean, that this is the whole point about peer review. I could say the same thing about anything published by Pfizer or by Oxford. At the end of the day, as scientists, we have to look at the data that's presented in front of us and see how robust it is. We challenge it, and then we either reject or accept. Now, if that has been properly peer reviewed and published in the Lancet, it's as bona fide as what's happened with AstraZeneca that was published on the same day.
Okay, thank you. John, you're raising your finger. Can I ask you to sort of look to your right? It's always worked better like that.
I just want to come back to the point you made, Giles, and this I would come back and ask Herb. I haven't seen the Chinese data. I know some friends who are getting vaccinated with it, but I haven't, and he said there was something out yesterday. I haven't seen the phase 3 data. And I don't think we can be claiming or asking for the science to follow the science when we're talking about the Pfizer vaccine, and yet say, well, I wouldn't accept phase 1 and 2. I understand Herb's view, which is it should be right, but I don't think we should be immunizing people based on phase 1 and 2 for the population at large. So I think we need to see that, because it's not just about efficacy too, it's about side effects, right? Yeah. And you can only get that from a large population phase 3 trial. So I don't know if Herb just wants to come back on that one point.
No, I agree with that, John, in the purest sense. But as I said, at least we've seen the phase 1, 2, and whether one likes it or not, millions of people in China have already been immunized without the full disclosure of the phase 3 data. And I assume, well, there's not enough transparency. This is our problem, but I assume in the modern days of information sharing, if there were some significant issues about efficacy or side effects, we'd be hearing about it, regardless of what the Chinese government wants to do.
I think we disagree in that, Herb, because first of all, their incidence of COVID is so low that it can't be effective, right? I mean, there's virtually none, so you can't get any efficacy data. And I have medical friends there. One of them only got it yesterday. She sent me the pictures of it. So I don't think they've been doing millions, and I don't think we can take the data from China because there's not enough cases there.
Yeah, but John, we've got the stuff from Brazil. We've got the stuff from Brazil where infections is rampant. So that is why they went to Brazil, and the data there is looking strong, and it's having independent scientists look at it, not just Chinese scientists. So I think the Brazil data is what hopefully we will see the publications shortly.
I'm glad to see healthy disagreement even within the Nottingham team. But look, I want to take a brief intermission. Phoebe, I'm sorry, I was forgetting about the slides, but let's have a quick canter through the slides. And then when we come back, I want to do a bit of a change of direction and talk about logistics and the sort of practical obstacles to ramping up the rollout in the UK, and then globally, who's doing it well? What are the lessons we can learn from Israel, for example? But first, over to Phoebe.
Hi everyone. Yeah, we'll do a quick canter through. We showed them at the start. So this is kind of some starting research for us looking into the vaccines. So this is that comparison chart, looking at different countries in the current vaccine rollout. I would say this is from the 6th. So I now know that that's been updated for the UK figures. And although Israel sits there on the third one down, currently they're sitting at about 17.6 per 100 people on their vaccination dosage, whereas we're sitting about 2.23 per 100 people. So they've had an incredibly efficient system for vaccination that we just haven't seen. And you can see France there as well, lagging right at the bottom, which has been kind of widely reported as well. So if we go to the next slide. And this is kind of spelling out that UK rollout plan. So this is what Johnson announced on the 4th of January, those first 4 vulnerable groups. It's about 13.4 million people. You can see at the top, the care home residents, all those over 80 years of age. And then we kind of come down to 75 years of age and over, and all those over 70 years of age and with comorbidities. So, you know, this is a large group of people. The questions around the speed of vaccination is important, but this is, again, and we will come to it later, is also about those that are most at risk and those that have been dying the most from, unfortunately, from COVID-19. And then we move into the next slide. So this is kind of spelling out the comparison of the vaccine. And I think we've had a kind of a continuing conversation about where efficacy sits in this, but you can see that Oxford AstraZeneca, the things we know is that the fridge temperature does make a difference. Cold storage is hard. I'm sure we can talk about how that's a global issue. Cold storage is not easy. And then we move to Moderna. And again, they're all 2 doses, but it sits at -20 and Pfizer BioNTech at the -70. So kind of looking at that efficacy, and you know, you have to be really careful and not compare. And I'm sure Herb would agree that it's quite easy to put percentages next to each other, but there's always complications. But so for the kind of to note, the Pfizer BioNTech, the first dose, then they were looking at was about 52% efficacy after 12 days, and then 95% after the second dose. And some of the research cited by the JCVI says that there's kind of they are looking and they're kind of assuming, based on some of the research, that efficacy goes up after a period of time. This is assumptions, but really at the end of the day, that's what we're looking for, is that 95%. And to kind of compare it to something, other vaccines, you've got the flu vaccine, which between 2015 to 2020 sat between 15 to 52% on efficacy, and kind of depends on children and each year as the flu vaccine changes. And then BCG and TB, so that's about 70 to 80% effective. But again, that's less effective against respiratory. So why we kind of want to spell out a tortoise, and I know we might do so in the future, is like really looking into that efficacy and how, because it's complicated. It's not as easy as putting those percentages together. And the next slide. And then we're kind of looking again and really sadly looking to the deaths. So you can see that spike, which I'm sure we're all familiar with, on the 70s, the 80s, and those above the age of 90. So between 70 and 90 plus, that's about 66,000 deaths, and that's about 84% of those deaths are those in that top 4 groups, and then kind of disparities on healthcare workers and those with comorbidities. But yeah, if those groups are effectively vaccinated, then that is a large proportion, but it needs to be done effectively. There's always space there on this. And then to the next slide. And this is the importance of the vaccine. So this is taken from it's not peer reviewed, but it is the study, the mathematical modelling cited by the Joint Committee on Vaccination. So this is looking at a comparison of vaccinations per day, per deaths. The optimal line is that following those age groups, those top 4 groups, those 10 groups that we've seen from the government. The unbiased kind of sits slightly above. So it does need to sit, but it is, vaccination per day comes into that, and it's a constant battle, and it's all dependent on the R rate. At the moment, the R rate is going up, it's sitting about 1.3, but as we see this new, more virulent strain, that's a worry as well. And what's kind of come across in these is that it's incredibly complicated. You know, this is not as easy, and I'm sure we can continue to have the discussion. It's not as easy as putting the things on the graph, and as more components come into play, as we have the next lockdown, and we have more virulent strains, it's going to be increasingly hard. So we need to have more data to go forward and really see the effectiveness of the rollout.
Thanks so much, Phoebe.
No worries.
I want to come back to Eva and Daniel in a minute. But first, if we could go to Peter Mason, if he doesn't mind having, I see there's a hand up there as well. We'll come to you, sir, Anthony. But Peter, one of the questions that we asked sort of in advance of this thinking was, are the worst predictions about rich countries jumping the queue going to come true? And Peter, you raised the question of vaccine nationalism. Is it your impression that we're already there and that we're in that sort of a horse race already?
That's just the impression I get from listening to the same press conferences that everyone else listens to. I think it's just the framing of things in terms of, outperforming Europe or the whole of Europe put together, which is just, I don't know, it seems to have no kind of factual relevance given the differences in the regulatory approval processes. And, more importantly, as I said in the comment, just it seems entirely, it's so short-sighted when you consider, where that actually gets you a few months down the line. If we do end up with those differences with European partners being, completely accentuated, I don't see how that helps us kind of achieve this normal dream of a normal life that we seem to that we want to kind of recover. So that was the point, and it just seems extremely short-sighted. It makes sense perhaps in the context of recent political developments, but just in terms of European and global public health, just very short-sighted.
I take your point, and of course it's always a risk when looking abroad for best practice is have other countries achieved a quicker rollout at the expense of other countries. It's so exciting to see an electronic hand raised. Thank you, Anthony. What did you want to say? Unmute. Can we?
Right, there we go.
That's good.
Yeah. I've got a lot of concerns about the vaccines from a scientific point of view, as well as ethical point of view. But just concentrating on today's discussion, the actual rollout, like we said, like the government keeps changing the parameters all the time. We've got a protocol for the vaccines, both of them. But what do? They change the protocol. Oh no, we're not having 2 doses 3 weeks apart. We're having 1 dose, and then you'll have another dose sometime in the future. Well, there's no rationale for that. There's no scientific rationale for that. All it is like, let's get as many doses out there as possible. That is not going to work. That is not going to work in a million years.
Okay, thanks for the point of view, Daniel. Let me ask, following on from that, as the facts on the ground change, isn't there a pretty solid case for changing policy and changing the protocol?
In terms of the doses?
No, I want to move on beyond the doses. We've spent a lot of time on that. I'm thinking more generally about the primary need to accelerate the rollout. Personally, I'd be inclined to cut any government quite a lot of slack in adapting policies towards that aim as facts on the ground change. Perhaps what I should be asking you to do at the moment is to set out 1 or 2 of the other recommendations that you've made in your report, and one of them in particular is to recruit 30,000 vaccinators. Where on earth would you get them?
Yep, thanks. As you said in your question, obviously we've made, or the government and the scientists have made incredible effort and progress so far to get to where we have already. So praise for that. In terms of accelerating, from the conversations that we've had with the suppliers, we think we could get to 3 million vaccines a week in January, 4 million a week in February, and 5 million a week in March, just based on speaking with the suppliers. That's a mixture of AstraZeneca, Pfizer, and I'm expecting Johnson & Johnson to be online in the coming, or approved by the end of the month.
Let's make sure I have that right. 3 million by the end of
January, 4 in February, 5 in March. I think Moderna may have been approved today, and I hadn't factored that in those numbers. So supply-wise, I think that isn't necessarily the problem for the country. It's more getting enough settings online and staffing online. The latest numbers I'd seen that we have 595 GP sites online now, which is only half of the available. 200 pharmacies have signed up or been able to take part of 11,000. So that's just the healthcare settings. There's obviously other places that we could think about: unused office space, bigger venues. So thinking about how we roll out polling stations, how quickly that's been set up, that's worth thinking about. So that's for settings. Staffing, as we said, having enough people to actually administer the jab is critical. Putting aside for 1 second Pfizer, which we've had a separate discussion on, AstraZeneca and Johnson & Johnson, I think are very straightforward, basically similar to flu jabs. So I think getting more people on stream for that is important. There's a huge 5,000 occupational health workers you could be using.
Daniel, let me just back up there. Sorry, are you saying that the business of injecting the Pfizer jab is more complicated because of the cold storage chain than administering the AstraZeneca one? I thought that they were both
and Johnson & Johnson, I think, are both more straightforward.
So less training required just to do the job.
And storage is easier. The settings that you can store it in are much wider. So I think that's why I think it's going to become the workhorse jab over the next few months. And then the staffing, you asked where that comes from. There's occupational health workers we could be using that we aren't. Obviously, the staffing from private health companies that have offered. I know there's thousands of cable staff there that have offered. Obviously, making full use of the pharmacies and GPs that we're not, is bringing online more staff as well. So I think supply for the UK isn't necessarily the biggest problem. It's making the maximum possible use of settings and staff, which, with the greatest respect to the government, I don't think are doing properly at the moment.
My colleague Matt Dancona in the chat was pointing out that a very, very small number of pharmacies are being used so far, even though they're routinely used for flu jabs. Do we have any idea why that is?
A number of them have approached the government to be approved. The biggest issue that I've found so far, I think maybe Matt might have some more information or others, is the threshold. They've got to be able to administer 1,000 doses a week. And then there's obviously this cold storage issue, which again is more relevant for the Pfizer jab. If you remove that threshold per week for jabs, just to make available as many as you possibly can, I think you're going to get a lot more online, probably more than half more online. And then the issue around storage, like I said, now it's going to be slightly less critical when we're talking about AstraZeneca and the J&J jab.
Okay. Now, I noticed that Paul Dinsdale in the chat is offering some reasons why the Israel example might not be applicable to countries like the UK. However, my colleague Zav Greenwood has done a little digging on this for Sensemaker Audio, which you can all listen to on Spotify. Zav, briefly, because we're at 3 minutes to, what's your impression that they do have a much higher number of jabs per capita than most places? Any lessons that the rest of the world should be learning from there?
Hi, I'm not going to turn on my video because my internet is quite bad and I think it will shut the whole thing down. Yeah, so kind of as explained in the chat, Israel has some natural advantages. So it's a small country, it's densely populated. It also has a healthcare system which is kind of set up for this kind of large scale rollout. It's a very digitized system. Everyone can download an app and can book an appointment really easily, can have a second dose automatically booked in for them. And so that makes the vaccination process very quick. One of the healthcare providers, Maccabee, says that it can vaccinate someone and do all the documents in just 7 minutes. And then their health system in general, since about 1995, everyone's been kind of on a mandatory basis signed up to one of 4 healthcare providers, which are government regulated, and those healthcare providers compete against each other and are, you know, free to access. And so I think having that competition while also having a healthcare system which is available to all Israeli citizens, not Palestinians, means that I think that's created kind of quite an agile situation in Israel where vaccination centres are popping up everywhere. I think the UK could obviously has some advantages, such as being small. But I think, for instance, the fact that it's less densely populated and people are dotted about means that they can't really imitate Israel in terms of having huge vaccination centres. I think it needs to be a more distributed approach. So, you know, the pharmacies which people are talking about and GP surgeries looks like the way to go. Thanks.
There is the point that I think you reported that they've also paid way over the odds for their initial supply at any rate. But John, you wanted to make another point, and then I'm going to come back to Eva finally before we end. John, whatever else you wanted to say, can I just ask you to address, as one of the proponents of going back to strict protocol for the Pfizer vaccine, how would you, if you had a public health hat on, compensate for the fact that that is going to shrink the number of people who can get a first dose?
First of all, I think that we don't know that by giving these people one dose that you're going to get the multiplication that has been said. The calculation has been put out there, you know, you'll have both your grandparents get 80%. The point is that the science doesn't suggest that. That's an assumption based on, if you hadn't given the second dose, it's an assumption based on the absence of evidence. You can't do that, right? So I think you go back to the science here, and it brings me to a final point, which is public behavior and public perception. And that is hugely important in this rollout of the vaccination. And I think the government's beginning to lose that battle about public trust in the science because of what they're doing. And you're getting, you're in danger of potentially getting, you know, vaccine hesitancy, because people say, am I really going to be vaccinated? I've had people give me 2 different opposing views of this. Patients. One is, if I take 1 dose, am I fully vaccinated? Am I half vaccinated? Or am I not vaccinated with, for example, with the BioNTech? If I'm only half vaccinated, but I behave as though I'm vaccinated, I'm just going to spread that virus again, right? So people are getting this mixed messaging, which I think is really important in the vaccine rollout. It's not just about the science that's important. It's not just about the, you know, the administration of doing it. We have to take the public with us, and they have to have confidence in the science, and they have to have confidence in the message that we're putting out there. Otherwise, they're going to behave in inappropriate ways. And even with the AstraZeneca vaccine, just to finish on that, although I think we all agree that it should be used, we shouldn't forget it's only 62% effective, which means that people, when they get it, this is a public health discussion. If we give that vaccine over the public, we will, you know, reduce the infection. But any one person can't assume that they can go out there and think they're fully vaccinated. And so we have to give the right public health message and the right.
Understood. Thank you, John. A little over time, but Eva, I did want to come back to you for the big picture. You made the point that globally, there are simply not enough vaccines being made to go around, and it'll be some time until there are. What would you say is the single most important message to deliver to governments and donors, thinking of COVAX, for example, to get that in, get supply and demand in better balance? Is it as simple as more funding for COVAX?
I think that the financing piece is huge and can't be underestimated. And at the rate that we're going, developing countries aren't going to have enough vaccine until estimates I've seen ranging from 2022, 2023, even out to 2024. And in light of the mutations that we're talking about, that's a disaster. So I think the big picture messages for governments and international institutions, one, and it's been said on this call and it bears repeating, the existence of the virus anywhere is literally a threat everywhere, since in some cases we don't know about the existing vaccine's ability to prevent transmissibility. I think that there are some questions that need to be explored. Some of those clinical trials didn't explore that as an endpoint. That's the first point. The second point is we don't want to be in a situation where relatively middle class, richer people in the global north are fully vaccinated and millions of frontline health workers in developing countries are not, putting whole populations at risk. The third thing is there needs to be more money. And, you know, God bless the UK and some of the Nordics and the Nordic countries and the Canadians and other countries that have contributed to COVAX. But the United States, now that we're having a change in administration, my expectation is that there will be a push from the Biden administration, some interest there in providing more funding, and then more bilateral donations. The multilateral development banks have set up special loan facilities, some cases grants, to support developing countries to access more vaccine. So some of it is money, some of it is a greater recognition from the countries that have a lot of vaccine that this is something about enlightened self-interest. And then I think that some developing countries are in better shape, like the bulk of our work at the Institute is in sub-Saharan Africa.
Right.
I think that they have a lot of strengths that they can build on when it comes to actually getting the vaccine in country. Many of them have great community health worker programs, and that's a great strength that can be leveraged. And I think it's a real opportunity in some sense. So I'll stop there.
Thank you, Eva. Thank you. Herb, can you do a 10-second hit?
Eva, I know we talk about getting this global spread of the vaccine, but demographics is going to be important as well. You know, in certain parts of Africa, for instance, a very large percentage of the population are young. So I don't think we have that same urgency. So, you know, everyone's talking about 7 billion people in the world, but in terms of where you really need to get it in terms of an urgency, we're not talking about more than 3.5 billion, are we? I think we're
going to end on the question, I'm afraid, because we'll get a bad reputation, even though this is a massively important subject, if we go too far over. But thank you all very much. Eva, Herb, John, Daniel. I think we've made progress, at least in my addled head, on the key distinctions between the Pfizer and AstraZeneca drugs, which may make one suitable for a longer gap and one less suitable. On the big picture, undersupply that has to be fixed, and Eva's point, the existence of the virus anywhere is a threat everywhere. With Herb's counter, that it may simply be more urgent in some places than others. And I'd just end by quoting Sudi Piggott in the chat, responding to John's point about messaging, which he says is crucial. People are confused, scared, but also some think when they have the vaccine, they can go out and play. Well, I certainly hope that's going to be true in due course of my parents, who've been shielding for nearly a year now and had their first dose yesterday. And I hope that everybody else gets it sooner rather than later. So I think I'll just end with Daniel's reasonably upbeat point, which again was a surprise to me, that you think that supply here, at least where the need is urgent, is not quite as much of a problem as vaccinators and locations. And I'm confident that with all the scout huts that we have, that can be solved too. It's 7 minutes past. I'm really sorry we've overrun. Thank you all very much for coming. Join us again next Friday for Sensemaker Live and for all the other thinkings in between. Thank you very much.